Good morning. Happy New Year to all of you. Good to see you up on this cold morning that I can't seem to accept as a Wednesday and not a Tuesday. So we're really lucky, though, this morning to have Dr. Bill Moss, who is in the Department of Epidemiology. He's a pediatrician. He did his medical school training and his pediatrics training at Columbia. He also did his MPH there. He described to me this morning his travels over the years and how he got to where he is today. It's interesting. You'll probably hear a little bit about, maybe hear a little bit about it today. So after his pediatrics training, he went to Ethiopia and practiced as a pediatrician there. He went back to Harlem Hospital, practiced as a pediatrician there. That's when he did his MPH. Then he joined Hopkins. He moved to Kenya for 2 years. When that project came to an end, he came back and did a fellowship in pediatric infectious diseases, worked with Diane Griffin, who I saw here somewhere this morning, and then came here through other means to the Department of Epidemiology, where he works on pediatric infectious disease epidemiology. So without further ado, I'll turn it over to Bill.
Thank you, and thank you all for coming out this morning. I hope you'll find this to be one of the best seminars thus far this year that you've attended. So I'm going to talk about an approach that we've used over the past couple of years to establish a sampling frame for studies in both urban and rural Zambia using satellite imagery. And I want to make kind of two disclosures right up front. First, I am not an expert in satellite imagery or spatial statistics, and I've been very fortunate to have very wonderful colleagues, particularly Tim Shields, Greg Glass, and Frank Carrero, who really did kind of the heavy lifting of the work that I'm going to present. Secondly, we haven't used this method specifically for clinical trials, but I'll come back to that point at the end, and perhaps we can have some discussion about whether this is a technique that would be useful in the context of clinical trials. So there's obviously a long history of disease mapping in epidemiology, and the iconic figure here that you're all familiar with is John Snow's depiction of cases of cholera in London, and their proximity to the Broad Street, famous Broad Street pump there. So this is, again, kind of the iconic image of infectious disease kind of mapping. Stephen Johnson, in his book, The Ghost Map, which is a wonderful kind of description of the history of this, the debate that John Snow was involved in between the contagionists and those who believed in the miasma theory of disease, and how this, his evidence really came to bear on that question, actually points out that Snow had two maps, this one that I think most people are probably familiar with, but another one depicted here. This is an artifact here, but where he kind of had this traced kind of irregular outline around the cholera cases. And this is kind of an example of what's called a Voronoi diagram. And what Snow did, and actually Stephen Johnson claims that this was really one of the innovative aspects of what Snow did. It was disease mapping had been done before, but what this outline shows are the individuals. It basically defines the population at risk. It defines the area in which people living within this area were closest to this pump as opposed to any other pump in the area for their water source. Not using Euclidean geometry, but actually the route that they would take along the specific streets to get to that pump. So it's what Snow did essentially was define the population at risk with this border here. And he obviously didn't use the mapping for deriving a sampling frame, but in essence, he used the map to define the population at risk. So my talk is going to kind of focus on those two uses of satellite imagery, one for disease mapping and the other for defining a population at risk or a sampling frame. Here's the outline of my talk. I'm going to talk very briefly about alternative strategies of sampling in kind of resource-poor settings, specifically settings where one doesn't have good or accurate census data or maps. And then talk about our use of satellite imagery, first in an urban setting and then in a rural setting in Zambia. Give you kind of a feel for kind of the nuts and bolts a little bit of using satellite imagery. Talk about some of the newer images that we've been acquiring and planning to use and some of the challenges raised by those. And then end up with a little kind of some thought experiments with using satellite imagery specifically in clinical trials. So I really have two main, rather straightforward, simple points in this talk. One is that the increasing availability of digital imagery, satellite imagery, provides this opportunity to construct sampling frames where census data or accurate maps do not exist. And then if one uses satellite images to provide the sampling frame, then it's a kind of a stepping point for doing sophisticated or simple spatial analyses of the data, because one already has the spatial coordinates of the households or individuals. So I won't spend a lot of time on this, but there are kind of a toolbox, an existing toolbox of sampling strategies that one can use in settings where there are limited census data or mapping. Kind of the classic survey technique or cluster surveys. These are the standard surveys used, for example, by the Expanded Program on Immunization to estimate vaccine coverage. They're called 30 cluster 7 surveys, where 30 clusters in a defined area are selected. 7 individuals within those 30 clusters are kind of sampled, and one can gather information that way. And other approaches are lot quality assurance sampling. Compact segment sampling is kind of a subset of perhaps cluster surveys where the clusters are divided into segments, and then one enumerates the entities within that segment. But all of these have limitations, and particularly, as I've emphasized already, the lack of accurate census data or maps. We were particularly interested, as I show you, in the urban setting in Lusaka, in informal settlements and squatter settlements, and those you're really likely to miss if you're relying on census data or existing maps, because they're not part of the official housing structure of the community. I'm going to show you a complex table. This is from our first paper kind of describing the use of satellite imagery, where we compare various sampling strategies, those that I've already listed. This last column here are those using satellite images against a number of different kind of characteristics. And I'm not going to go through all this, and I just want to say you could kind of look at this comparison. But it's really the sampling frame is one of the strengths of using the satellite image, that these other techniques really don't have a really well-defined sampling frame. So let me talk first about a study we did, which may have been one of the first, at least the first to my knowledge, examples of using satellite imagery to define a sampling frame in Sub-Saharan Africa, and so this was a tool that was used as part of a study where we were interested in doing. Just the background here. Diane Griffin and I had long been interested in interactions between measles, the HIV epidemic, and measles vaccination in children in Zambia, and did a series of studies, starting with hospital-based studies, then a clinic-based studies looking at vaccine responses. And this was really an attempt to do kind of a community survey and look at population immunity in a defined community in Lusaka, Zambia, which is the capital of Zambia, and really define the prevalence of both measles vaccination and measles seropositivity in this population. And we had done the clinic-based study in this urban township, very densely populated urban township, very poor township of Lusaka, Zambia, where we really didn't have good census data or good maps, and wanted to do a survey, and we're thinking about ways to do a population-based survey. And so we came upon the idea of using a satellite image to do this, to define the sampling frame. And so here's Lusaka, Zambia, and this is the township. It's actually multiple townships, but it's largely a township called Chawama. Those of you who've been to Lusaka, kind of downtown Lusaka's here. This is the Kafui Road coming out, going south into southern Zambia. And so this kind of population here, almost in this triangle, was our defined study population. And so we were able to purchase this image, satellite image, from a company called Digital Globe. It was taken by a QuickBird satellite. This was an already existing satellite image, and I'll come back when we talk about the work in rural southern Zambia, what the implications are when there isn't an existing image. It's largely a cost implication. But we could obtain, this was roughly a 25 square kilometer area, and we could obtain this image, actually it just took 24 hours once we put the order in, for $350. So this was this was very low cost. What was driving the low cost here was the relatively small study area and the fact that this was an already archived image. So what we did, and this, again, Tim Shields, Greg Glass, and Frank Carrero did the heavy lifting here, along, I should say, with Sarah Lowther, who is the doctoral student in epidemiology, who this became her doctoral thesis project. So Sarah did a lot of the heavy lifting, too. I'll mention what she did. But so this image, once we had it, was brought into ArcGIS, which is a GIS software. All the households, this is what Sarah did. She digitized all the structures that appear to be residences, and I'll show you a close-up image here. Basically enumerated manually by placing a centroid on each of the potential residences. And then ArcGIS creates an attribute table for each of the identified structures, including geographic coordinates. And then once Sarah had enumerated all the structures, there were over 16,000 in this 25 square kilometer area, a very densely packed community. We were able to, through a random list, randomly select our sample size of 750 households. And this process of enumerating them took approximately 2 weeks. And so this is Sarah's work here. And so this is a close-up region. Now I should say that these are all single-story structures, and I'll come back to kind of the limitations of this strategy, but one would really have to adopt this. Perhaps it wouldn't even work in an urban environment with large apartment buildings. You'd have to think about another way to use this, and we haven't used it in that type of setting. So this is an impoverished, again, urban township with single-story structures. But basically, you can see Sarah kind of drop these dots on each of these structures. They're relatively distinct here. Now, sometimes there's a judgment call here in whether a particular structure is likely to be a residence, and this is one of the challenges of using this technology. For example, a larger structure like this, is this a residence or is this a school? There are some very small structures. Some of these very small structures turned out to be, say, public toilets. Some of these larger structures, churches or schools along the main roads. They were more likely to be shops. But we were conservative in really considering all the structures that looked like they could be a potential residence. This was actually we were able then to define segments. So we didn't have to rely on kind of existing maps and existing geographic boundaries. We could create our own boundaries. This red line indicates a road, so we could map the roads. These green lines indicate main paths. this was part of a pilot study where these blue houses were the selected ones, and we kind of pilot tested whether our field team could go out and find these structures based on satellite images. I just want to mention, this is somewhat of an aside, but how we did the community mobilization in this urban setting, because this was kind of fun. There was an existing dance and drama group within the community that we found, and they were just wonderful. We told them about the project, that we were interested in measles and measles vaccination coverage in the area. We told them about the study. Now, the way we did this survey, which was essentially a serological survey for both antibodies to measles virus and HIV, was we used oral fluid. That was kind of another somewhat novel approach here. We knew that in this community, going to people's homes and asking if we could draw blood from their children, we were likely to get a high level of refusals. And so we used oral fluid assays where one can measure antibodies to both measles virus and HIV with some loss of sensitivity. And so we told this drama group how we were going to, what the study was going to be, and they came up with a skit that first kind of talked to the community about the value of measles vaccination and the dangers of measles, and then they went through actually the various study procedures in this skit. And here's Sarah here in the back, and they would go into these kind of clear areas. Here's a football pitch, soccer pitch. They would go into areas like this or centers, maybe here, and start drumming. They had a drumming group, and then they would start dancing, and this huge crowd would form around them, and then they would go into this skit kind of promoting measles vaccination, and then describing the study procedures. And here he's holding up the oral fluid swab that we used to collect the oral fluid sample. One of the men in this troupe was dressed as a woman, and that was like the biggest hit. To have a man dressed as a woman acting like one of the mothers, people just thought that was hilarious. And so this was how we did the community mobilization, and we selected various areas of the community. So basically, we formed these survey teams, and we hired 7 biomedical students who are on break, and used 21 local community health workers who were actually assigned to, basically, their assignments covered the study area. So they were very familiar with the community, and the people knew them. And so we teamed the students who would do the data collection and the sample collection with the community health workers. And we worked out of the clinic, and we would start off with the teams in the morning, Sarah and I, and we had a large kind of 3x5 foot printout of the satellite image, and we would identify on that image where the team was to go for their selected households that day. And then we had printed out of the selected households kind of satellite images of different scales. One of the things we weren't sure was how these people who had never seen satellite images before, never seen their community kind of from a bird's eye view from above, how they'd be able to, really then move on the ground and identify the selected structures. So they had printed images at different spatial scales, and basically walked to the selected households and would mark on their printouts, where they were. And they would use, there were obvious landmarks that they could use and that they were familiar with to find the households. And then we had a mechanism or algorithm for if the household, if there were no eligible children, or they refused, or no one home, how they would move to the next structure. And so this is a summary table, and I won't go through all of it. I just want to highlight some of the things here of this process. So there were over 16,000 structures within this 25 square kilometer area. We had randomly selected 750. Only 6 of these, they ended up going to all 750. Only 6 were not found. And then it turns out only 48 or 4% were actually not a residence. Again, the larger structures were likely to be schools or churches. Some of the smaller structures, shops or public toilets. They ended up finding 691 households that had children who were eligible and were enrolled, but they did assess a much larger number of structures, basically almost twice the number. And so this is again one of the limitations here. Although this would be a limitation of many other kind of survey techniques where you go to households and there are no eligible individuals or people refuse. So one of the neat things we were able to do was to, and Sarah and Frank really did this work, was to, we now knew which households were enrolled and which that we went to were not enrolled, and we could look to see whether there was any clustering of non-enrolled households. And this is a visual image where the enrolled households are indicated in green. You can see our subdivisions with these red lines. And then the red households are those that refused. And just kind of eyeballing it, you can see perhaps some small clusters of non-enrolled households. And our field team told us kind of anecdotally that sometimes when one household refused, I mean, these are very close together and people are watching very closely what their neighbors are doing. One household's refuse that the adjacent household were also likely to refuse. So there's kind of perhaps psychology around clustering of refusing households or non-enrolled households. And so Frank and Sarah used this K statistic here, which is to actually demonstrate this statistically. So very simply, this K function takes the expected number of events. Basically, it's a statistical method that's used for spatial point data, and one takes kind of an arbitrary point and then defines various distances from that point and calculates an expected number of events, or in this case, households within that area, and then basically scales it for the size of the study area and the number of events, or in this case, households in that area. And basically, this is a K difference between the K function for the enrolled, basically it's the K function for the non-enrolled households minus the K function for the enrolled households. And just very simply how you'd interpret this, if there were no spatial clustering, this K difference should be 0. So that's this line here. We used Monte Carlo simulations to generate these envelopes, and then this is the K difference function for the actual data. And the larger this is, this K difference, the absolute values don't have any kind of intrinsic meaning, but the larger this value is, the more clustering there is of the non-enrolled households. And so you can see the data, this K difference for the data is outside this envelope. And so this shows statistically that there was clustering of the non-enrolled households. So that's one thing, one way, once the sampling is based on a satellite image, then one can do very easily these types of analysis. Jim?
So one piece that you haven't talked about yet is how do you handle residences that have been built since the time?
Yeah. Yeah. Right.
For the image is now a few years old.
Right.
You're subject to this.
Right. No, that's a great question, and I'll come back to that. And we have faced that. I mean, this image was taken fairly close to the time that the survey was done, and this is although people may be moving out, there wasn't a lot of new structures in this area. But that's a problem we face more in southern Zambia, and I'll come back to that. But that is as the image gets older and older, particularly if you're in an area where new structures are being built or people are moving their homes, that's a problem. Yep. So this just shows the output of the results of that study, and I just want to point out, so you get we had these prevalence estimates, and I think we could have some confidence that these weren't due to selection biases because of the sampling frame that we were able to do. And then once one has the spatial data, one can do different things. So we asked, for example, about measles cases. We were interested in whether the mother reported whether or not these children had had measles in the past. And there's obviously some recall bias in this, and there weren't a huge number of cases, but we could not only generate a temporal sequence, a temporal analysis of the reported measles cases, but also look at it spatially. Perhaps more interesting was this analysis, and what we have here, again, what I'm just pointing out is ways one can use then the spatial data that one has to do different types of analyses. So we were interested, the specific question here is whether the children who were susceptible to measles were HIV seropositive as well, whether the HIV epidemic was contributing to this pool of measles susceptible children. That was based on prior studies we had done looking at that showed that HIV-infected children who were vaccinated against measles had waning immunity. And so this was a way to look at this spatially. So what this panels A and B show, these are the children in individual households and where they're located. These kind of bluish or turquoise circles represent children who were vaccinated against measles and had antibodies against measles. So these would be vaccinated, protected individuals, children. And the red dots were children who were not vaccinated and did not have detectable measles antibodies. So these were the susceptible. So we're kind of mapping seropositive and susceptible children here, and then could use more sophisticated spatial analysis techniques called basically this spatial intensities, and basically this is generating a ratio of susceptible to protected individuals smoothed over the entire surface, and the areas where at highest risk are the yellow to white areas. So it looked like there was some kind of clustering, if you will, of susceptibles actually at the two extremes of this community. And then we did the same thing with HIV seropositivity. The red dots here indicate the HIV seropositive children, the blue dots the HIV seronegative children. And our hypothesis was that these two areas would overlap. It turns out they were actually the opposite, where most of the HIV, this kernel intensity mapping showed that the HIV-infected children were more likely kind of in the central. And I don't have a good kind of explanation or causal explanation of why we saw that basically counter to what our hypothesis was. But the point here is to show the types of analyses that one can do. So that was what we did first in this urban setting. And then with the Johns Hopkins Malaria Research Institute, we started doing community-based surveys of the prevalence of malaria parasitemia in rural southern Zambia, and decided to see if we could use satellite imagery in that area as well to define the sampling frame. So in this area, so this is Choma district in southern province in Zambia, very rural Sub-Saharan Africa with very low population density. There were no existing images, no archived images that we could draw upon, so we had to order through the same company, Digital Globe, that a satellite image be taken of this area. And you can see the cost was much higher. And that, again, two reasons. One, the area was much larger. This was over, so I should define this. So this is the satellite image. Our initial study area in 2007 was this blue area here, and I'll tell you why. Our subsequent study area is this red area here. This is Macha Hospital, and where the Johns Hopkins Malaria Research Institute is based. So that's kind of our home base there in Macha. This total area is about 1,100 square kilometers, so much larger area that we have the image of. And because it wasn't an archived image, we had to have a new satellite image. So the cost was, this is very expensive, obviously, to do. I would think that over time, there'd be more and more kind of archived images that one can draw on, but one would then still run into the problem that Jim pointed out, because they're dated, and I'll come back to that. We initially worked, so we're based here, we initially worked out here because as we were getting this up and running, and tried to get a new satellite image of this area, it was actually during the rainy season. in Zambia, and so there was too much cloud cover. So this is also a problem, when your image is taken, that we couldn't see. So we were kind of forced to use an image out here where we didn't have enough, where there wasn't a lot of cloud cover, and so that's where we started. And it turned out that was very difficult for the field team to get to. There are no paved roads in here. There are a lot of rivers, and actually crossing the rivers in the rainy season when the bridges were washed out proved to be logistically very difficult. So we ended up the next year being able to get a clean image here and moved our study site over. And there are obviously disadvantages in moving your study site, but that's what we did. And so this is a close-up image of the Macha area, and you can see very different than the urban township. And so here we have, instead of kind of counting or labeling single structures like we did, these homesteads, we'll call them, or households, consisted of multiple structures, and that's very typical of rural sub-Saharan Africa. This is actually these are actually Tonga people, which is a polygamous society, so there tends to be one man and multiple wives. Each of the wives have their own kind of hut, and the children live with the wives. So you have, and then there are cattle corral and various other structures in these homesteads. So here we labeled. This would count as one unit, one sampling unit, as opposed to the single structures in the urban center. And you can see there's really, they're fairly well defined, but again, this is all done manually as well. There are judgment calls about, what constitutes a single sampling unit and what are multiple sampling units together. People have we've done all this manually. People have tried computer algorithms to do this, and I know Tim Shields tried that and really didn't find it to be effective here, but there might be more automated ways to actually digitize some of these structures. So for these surveys, we had 4 to 5 full-time field workers. They were given a list of randomly selected households and the coordinates, and instead of using kind of printed images, this team was very knowledgeable in using GIS and GPS devices. They were given GPS devices, and they would use the coordinates. They also knew the study area fairly well, so they knew roughly where the household was, and then they would use GPS devices to actually locate the selected households. They had to use vehicles because of obviously the large distances here. And then when they got to the household, they would obtain the GPS coordinates so that we can confirm that they actually went to the selected household. So when they went to the household, and this is kind of a typical, household, these kind of mud-walled, thatch roof homes, they could do a lot of things, and they collect information and blood samples and dried blood spots and things. So we can do a lot of things on these surveys. So this is the satellite image in the background. All of the households that were identified or structures are indicated in these brown dots. And then the green and yellow dots are households that were enrolled. So there were 8,751 households in this area. This is actually combining both the 2007 and that 2008 study area. So you can see roughly half the number of households that we had in that very densely populated urban environment, although over much greater area. The yellow circles represent households in which an individual was RDT positive, rapid diagnostic test positive, so kind of a confirmed case of malaria. The green dots where an individual was not RD positive, and this is aggregated over an entire year for each of these. So there's no kind of seasonality displayed in this graph or in this image. And then these are rivers, and I'll come back to that mapped here. Of various orders as a classification stream for streams, rivers from first order to fifth order. So this is kind of how it looks, and you can see that that the households aren't obviously randomly distributed over this area. There's clustering. And so one of the things we needed to assess was really whether our sample was representative in terms of the ecological characteristics of these households. So again, we can get point prevalences of, or period prevalences of malaria in these areas. The striking thing is that malaria has gone away, or going away in this area. But again, and be relatively confident that this is not due to selection biases. So an interesting thing that we were able to do with these data, and this was largely Greg Glass's work, was to take that satellite image with the households, all the households in the area, and the selected households, and those that were RDT positivity, and link it with another data set that Greg accessed of remote sense data. So these were data obtained from the shuttle radar topographic mission in 2001, and that kind of data allows one to really characterize the ecology of the area. So specifically, one can determine, based on the reflective properties of these data, the elevation, slope, landform. One can do hydrologic modeling to determine flow patterns of water. And so Greg took these data from these topographic data and overlaid it with our satellite image in households. And basically, we were able to then create a risk map of malaria. And that's what you're seeing here with the areas kind of in yellow, projecting in kind of a yellow or the lighter colors, or even orange here, the areas of highest risk of malaria, and the blue, the areas of lower risk. And the way we did this was we brought those ecological characteristics into that attribute table for each household, and then used actually logistic regression to determine, what ecological factors were correlated with an RDT positive household. And it turns out elevation was one, and that's not surprising. But also distance from these order 3 streams, these black streams, was the most significant kind of correlative of RDT positivity. And hence on this risk map, you see these lighter areas, these higher risk areas around these order 3 streams. We don't quite yet understand kind of the biological basis for that, but probably one could hypothesize that the larger streams had the water flow was too great for mosquito breeding, and the smaller streams just too small. So this was kind of the ideal breeding site, and I'll come back to that. Yes. Yeah.
Do people use mosquito nets in this area? This would also be maybe something to take into
Yes. Exactly. Yes, and we have data on ITN use. And so those were kind of rolled out at the beginning. In 2007, there was a mass distribution of that. And so that also was factored in. Yes, very important. And so we were able to kind of create this risk map of malaria transmission. We then actually validated it with incident cases from 2009 and showed that it had fairly good predictive power in determining where the incident cases were the following year. Now, how stable this is over time is not clear. Julie Clennon, a postdoc of Greg Glass's, did some looked at mosquito breeding sites and created her own risk map, actually independently of this risk map, based on vector breeding sites, and they're remarkably similar. Again, perhaps not too surprising, I mean, in retrospect, that the malaria cases are going to be closer to the breeding sites, but kind of validates the mapping approach. So that's kind of the work that we've done. I want to talk a little bit about kind of where we're going and some of the new images that we've gotten and some of the challenges faced with that. So the image, this comes back to Jim's point, the image that we've been using for Macha, for the southern Zambia region, was from 2007 and 2008. So now it's 5 years old. And we know from our field teams that they've reported to us that they've gone out and, a selected structure was no longer there. So we can basically tell when a selected structure was no longer there. It's a lot harder to get information on whether new structures have popped up, although certainly they have. So we've just purchased within the past week or so, a new image for matcha. And so what we're very interested to do is to compare the two images and really see in this area how much they've changed. Basically, how many new structures are there and how many of the old ones have disappeared. Now, that's going to be very context specific. So one won't be that's not generalizable kind of information, but it'll give us a feel for, at least in this area, rural to kind of a somewhat typical rural sub-Saharan Africa setting, how much change there is in this population. So we've selected actually this green area. This is kind of our current study area in these grids. We've getting a slightly larger image here in this green area, and I just want to point out, so we were able to use archived images that were obtained in 2011. I'll show you them in the next slide, from a different satellite, GeoEye satellite, a different company, kind of a break-off company called Apollo Mapping. These cost $8.75 per square kilometer. This green area is roughly 1,200 square kilometers. So this image costs roughly $11,000. So lower than what we had paid before, because we're able to use archived images, although still a substantial amount of money. And as I pointed out, this updated image will allow us to compare the two images and see how things have changed. So this is what we have now, and just a couple things. The image of our study area is actually based on pieces taken at different times. And you can actually see this image was probably taken during the rainy season or shortly after, and this during the dry season. So you can get the vegetation changes markedly during these seasons. And I just want to point out that, and Tim does the heavy lifting here, but this takes a fair amount of work to kind of put this together. These different images have to be stitched together and then geo-rectified so that the coordinates are accurate. So I don't want to give you the impression that this is something you kind of just buy off the shelf and ready to go. It takes a fair amount of work by a skilled person to do this kind of work, but it's obviously not insurmountable. But this made it less expensive because we were drawing on pre-existing archived images rather than a new image. But this is one of the limitations of doing that. So in part of our malaria work, we're now starting in two different sites in northern Zambia, in Enchilenge district, and in Mutasa district in Zimbabwe. And this is the current existing map of Enchilenge district, somewhat tongue-in-cheek, but this is from one of the health clinics there, and showing the map. And so this provides information, but there's limited what you could do with it. We were able to, now, with Google Earth, obviously you can at least get some imagery, perhaps not as high resolution as one needs to do this kind of sampling. But this was from Google Earth of Enchilenge district. We were kind of looking at defining a study area. This is Lake Meru, so this study area is right on the lake. High population density along the lake here, and then it kind of decreases as one moves away from the lake. So very different kind of ecology, very different population distribution than in rural southern Zambia. And this created kind of additional challenges for using, that we're now kind of working through in using satellite imagery. These were, we sent a team there this is the main road, actually runs along the lake here, and they obtained GPS coordinates. And so those are kind of coordinates mapped on there in an attempt to kind of geo-rectify the image. So we went ahead, we bought a high resolution satellite image of this area, and this is the high resolution image. So this is our purchased image. That prior one was kind of publicly available. We're trying a different sampling strategy here with the help of Tom Lewis in biostatistics. We really have kind of no idea of the spatial distribution of malaria in this area. We suspect there may be a gradient from the lake inward, but not entirely clear. Also, there were many more structures here than there were in the southern Zambia. So we faced the problem. Part of it's just kind of a logistic burden problem of, do we really need to manually enumerate all these structures in this area? And we decided to, at least as a first pass, and I'd be interested in thoughts on this, but as a first pass, to kind of select grids. These are 1 kilometer grids, maybe 5 kilometer grids. Should have had the scale on here, but so we selected these grids to kind of get some diversity, ecological diversity, and then enumerated all the structures within those grids as a way to cut down. So this is a very different sampling strategy that we're trying here, rather than kind of the simple random sampling strategy that we were used in Matcha, and then select households within these units. We didn't do it proportional. We didn't do a proportional sampling because some of these areas, like say this one, where we want to get at least some data from, had very few structures. So we kind of oversampled, over-selected, households in some of the grids with very low numbers, and under-sampled relative to proportionate sampling in some of these. But so this is the strategy we're kind of trying in Challenge, at least as a first pass, to get a better feel for some of the spatial epidemiology of malaria transmission. This is the map for Mutasa district in Zimbabwe. And I just want to point out two things. We're trying the same strategy here with different grids. These are clouds, so this is what cloud cover can do. And this is a very deep valley, and this is actually a cliff right here. That's why the clouds are kind of hung up. But I just want to, one, show you what cloud cover can do. And two, what's going to interesting here, which is a different challenge, is obviously in all of these, we're taking a three-dimensional surface and converting it to 2 dimensions. And in Matcha, on a plateau, that probably wasn't a problem. But here, it may be more of it's a slightly bigger issue, because we were down, and this is down in a valley. And so there are some interesting problems, I think, with particularly in areas where there's a lot of range of elevation in using these 2-dimensional surfaces. So I'll just kind of end up with talking about, kind of bringing this back to clinical trials. I searched PubMed and clinicaltrials.gov to try to find any use of satellite imagery for a sampling frame in a clinical trial, and couldn't find anything. I don't know if anyone is aware of anyone. So I'm not sure this technique has been used in clinical trials, but I kind of picked 2 examples as kind of thought experiments. And I think the main use, I would think, would be in cluster randomized trials. And so I picked just kind of 2 recent cluster randomized trials. This one published in The Lancet not too long ago. One related to infectious disease, malaria, where spatial patterns are very important. This one where spatial patterns are less. And I thought we could kind of use this as an exercise to think about whether satellite imagery might be a useful tool in this kind of context. So this was a very large study, basically looking at the impact of promoting exclusive breastfeeding by peer counselors. It was in 3 countries, a large number of clusters. Their main outcomes of interest were exclusive breastfeeding and diarrhea as an outcome. It's interesting, they did see an impact on the prevalence of exclusive breastfeeding, but no impact on diarrheal disease. But in supplementary materials, they rather briefly describe how they selected the clusters. And so they involved the community leaders, and then took descriptions of the infrastructure, roads, water, various health facilities, and one can obviously map these using, onto satellite images, and we've done that. Various geographical characteristics, they don't really define what those are. Socioeconomic and cultural characteristics, obviously, you can't get from satellite imagery. And then statistical information from relevant administrative lists, national statistical bureaus, or prior studies were used to estimate numbers and geographical sizes of clusters. So I thought this was an example of where I think, using satellite imagery might have been very informative, particularly for the collection of of these data where they were relying on again, perhaps older data and data that may not have been accurate. Now, this study was done in 3 countries, very large geographical area. If they had to purchase satellite images, it probably would have used their whole budget. So I think there were economical reasons why, but I think kind of from a theoretical point of view, it might have been useful. This was another recent study. This was a cluster randomized trial of mass drug administration with a gameticidal drug and drug combination to interrupt malaria transmission in a low endemic area in Tanzania. So what they were interested in, this was an area where they'd seen malaria transmission go down. They wanted to try to eliminate malaria transmission by eliminating the gametocite, so they used this drug combination. And they used GPS to map the various households. So these are the different communities. They had there were 8 clusters in the intervention and 8 in the control. And these are the kind of maps that they show in the in their paper. And again, I think this might have been an area. I'm just promoting this, but you know, where satellite imagery may have been very useful in mapping the households, and they could much more clearly perhaps show the relationship of these households and clusters to various bodies of water or potential breeding sites. I mean, I guess this is one of the, I'd be interested in Stephen's view on this, but you know, one of the real challenges in doing cluster randomized trials in malaria is that the epidemiology is so focal. So really matching your intervention and your control clusters is really critical. What was interesting in this study is that they saw a decline in malaria in their intervention. Basically, there was no malaria in their intervention clusters, but there was no malaria in their control clusters as well. Malaria had just kind of on its own transmission decline, and so they weren't able to draw any conclusions about the intervention. Basically became a feasibility study, which was probably disappointing after all the work they put into this. But it's one of the problems, and malaria epidemiology changes dramatically from year to year, so doing kind of pre-post studies is also very problematic. So kind of in summary, what I hope I've done is kind of shown you some of the strengths of using satellite imagery. It allows for random sampling in settings without census data or maps, facilitates the spatial analysis once one has those data. One can map, I didn't show this, but one can map roads, health facilities, river, or it showed some of this, rivers and other natural features of the landscape. You know, get that information from the satellite image. But there are limitations. I pointed out it's a 2-dimensional representation of a 3-dimensional surface. At least for us, you know, it obviously depends upon the sampling unit, and but if the sampling units are households, it really is dependent on single story or single family, I think, residential dwellings. Again, I'm not sure how one would use this in Baltimore, for example. You obviously don't get information on number of ages of individuals, which one would get from census data. There can be obstructed view from cloud cover or vegetation. So in these highly seasonal areas like Southern Africa, you know, the most useful images for our purposes were taken during the dry season rather than the wet season. Although the vegetation is really not enough to cover structures. They're generally in a clearing. And then again, as Jim mentioned, population mobility and migration is a big problem in dating these images, and how long in a particular community will these stay accurate. So I just was going to end up using kind of the papers upon which I drew from, in large part just to thank the people who really did this work. So this was our kind of first paper on the feasibility in the urban setting, and Sarah did this work with Frank and Tim, and then this was the actual study published in the Lancet with Sarah and Frank and Tim, and then recently we published the use of the remote sensing data, the maps, the risk maps I showed you with Greg Glass and Julie Clennon and Tim. So I'll end there. Yes?
Questions?
Jim.
Well, I can tell you there is one trial about to start that you can tell you.
Okay.
Baseline. Malaria and iron trial in Zimbabwe.
Mm-hmm.
one of the issues that's come up, of course, and we're using it to try to cluster, define clusters and things like that, but to get size, basic size estimates. One issue, of course, is we want to also use that potentially as a logistical issue, but the terrain is hugely varied, and so Euclidean distances are irrelevant to functional distances when it comes to logistical management.
Right.
It's very useful for that.
Yeah. In terms of altitude, or yeah.
And a difference of 50 or 100 meters in altitude means one thing when it's a nice gradual slope and there's a path, and then another thing if it's a cliff. Right. I guess the other thing is that I think it's really important to have kind of field adaptive methods for teams to assess both under enumeration of dwelling units and over enumeration of dwelling units based on these strategies. So, and you can do simple things like always look to the house either direction, north or south, or next door, either direction, left or right, as you're facing the front door. Is that one on your image?
Right.
That one on your map? Is it a real residence or is it not on your map?
Right.
Things like that.
Right.
Get some idea of how
we certainly could have done that in the urban setting. In Macha, I'm not sure the households are so far apart. I'm not sure you could even see them from one. But that may be true in Enchalengue, for example, where the population density is higher, where we could try to, at least to give you some sense of the accuracy. Yeah. Yes.
A quick question about you mentioned how in Lusaka how you weren't sure if this structure was a residence or a school.
Right.
Did you have in your protocol how the health workers would handle that kind of structure if it was on their list in order to maintain the randomness and the sample?
Yeah, so basically, there are various ways of doing that, obviously. We just had them go to the house, they would face the household and go to the household to the right, which is kind of a strategy that's used in the 30 cluster by 7. So we kind of adapted it from that. But one could, we talked about, so in our new studies, we're going to use tablets, electronic data collection. And we've talked about various ways of using, if the field workers actually have a tablet, they could pull up another a household perhaps randomly within some certain radius. You could get much more sophisticated in how you randomly select the next household to go to. We thought about just a little board game spinner, and just spinning something. But so it was basically go to the house on the right, adopted from the 30 by 7 cluster. Bill.
We did a national survey on summer where we graded the country with population density grid, and then we overlaid it with 25 kilometer squares. It's a cluster survey.
Right.
Like 100 clusters, but probability proportion to density.
Right.
And once we got to the 20, once we selected each 25 kilometer square, we overlaid a 10 by 10 meter by 10 meter grid on that size of the household. And we just randomly selected the grid. And if you look at it, there's an open area. You go to the next one.
Right.
Until you found a household. If the grid was over 2 households, it's the one that had the most of the roof. And it should save having to
Enumerate. Yeah. Okay. That's a good point. Yeah. You just have a kind of a hierarchy of grids, and you're selecting with it. Yeah.
Population density grid.
Yep.
Also helps you select the data you want to do.
Right. Right.
How did you get the initial population density?
That was available. We had Simon Fraser did the heavy listing.
Yeah, because so you got to have the population density originally to be able to do that.
Yeah.
Way back to
Those were available.
Yeah.
3 data sets, but that was 1 kilometer squared. And it's for lifetime, and it's for overall, it's really available, 1 kilometer squared.
Yeah, but just to give you an example, so the only data that will be in that for Nepal are 11 or 12 years old, right? So so if you're trying to do something now, because the new census data aren't out yet, it's got to be based on something.
It's based on, it's based on a couple of things, including census data, including,
In other words, model. Model census data, right? Well, so you're back to census data. So it depends on how old your bases are for actually doing that.
When you actually select the household, then new neighborhoods come up.
How?
Do you think certain diseases or, for example, I mean, ecological factors, and if you are doing a serological survey, I mean, these lend themselves, if you do cluster sampling, you sample from above. But things like breastfeeding, for example, I just wonder, I mean, the issue of breastfeeding or certain attributes or risk factors is different from, for example, sampling for diseases that have some ecological correlation.
Right, and that's actually why I picked that example, because it's less obvious that it has that that there are ecological correlates. Although one could, I guess, hypothesize that there may be clustering of exclusive breastfeeding because women influence one another in a social network.
Or there are ethnic variations in distribution, and they have cultural patterns of breastfeeding.
Yeah. So I think there can be spatial patterns of breastfeeding, but not related to the ecology, obvious things in the ecology, altitude, slope, those kind of things that may influence malaria transmission. Vector-borne diseases are going to be very strongly influenced by ecological factors.
Like cultural ecology.
Yeah, cultural ecology. Yeah, you could term it that way. Larry.
So on a historical note, I think the first time I remember seeing this kind of thing in the school was when Alan Ross was using airplanes to do the So now they probably use drones.
Yeah, but he used to, I remember he used to tell the stories about ground truthing those days, like sitting in the back of a Jeep and driving along the roads and having the.
So he would take photographs out of an airplane over Afghanistan. That's interesting. Yeah, I wouldn't do that today, but. Okay.
Well, thanks very much.